The standard inferior alveolar nerve block is used worldwide for producing mandibular anesthesia. The target for the inferior alveolar nerve block is the mandibular sulcus, just superior to the mandibular foramen and behind the lingula, a bony prominence on the ramus that anchors the anterior attachment of the sphenomandibular ligament. Deposition of anesthetic in this region will bathe the inferior alveolar nerve just before it enters the mandibular foramen.
Intraoral landmarks are key to this injection technique. The height of the injection is established by the greatest depression of the coronoid notch, a concavity on the anterior lateral border of the ramus. With the syringe held parallel to the mandibular occlusal plane and at the level of the coronoid notch, the needle will be in a plane that intersects the mandibular sulcus. Because of the lateral flare of the ramus, the syringe must be advanced from the contralateral premolar region for the needle to enter the sulcus. Clinically, the coronoid notch is determined by palpating the most lateral aspect of the anterior ramus. Here, the thumb, kept parallel to the mandibular occlusal plane, is moved into position within the coronoid notch. A line bisecting the thumbnail establishes the height of injection. The insertion point itself is on this line just lateral to the pterygomandibular raphe, the soft tissue roll that denotes the junction between the buccinator and superior constrictor muscles and marks the medial border of the pterygomandibular space. The lateral border of the space can be determined by palpating the deep tendon of the temporalis muscle on the temporal crest of the ramus. The insertion must be made medial to this landmark. With the patient's mouth wide open, the thumb is placed over the anterior border of the ramus and pulled laterally, retracting the cheek and the buccal fat pad until it rests within the greatest depression of the coronoid notch and is made parallel to the mandibular occlusal plane. With the syringe oriented over the opposite premolars, the needle is advanced to the insertion point, lateral to the pterygomandibular raphe, and at the height of an imaginary line bisecting the thumbnail. The needle is then inserted slowly through the mucosa and buccinator muscle and into the pterygomandibular space. A few drops of anesthetic solution delivered as the needle is advanced may help reduce the discomfort of needle insertion. Once bone is contacted after an insertion of 2 to 2.5 centimeters, the needle is withdrawn slightly and an aspiration test is performed. After a negative aspiration, approximately 2/3 of the cartridge is injected at a rate not to exceed 1 cartridge per minute. If lingual nerve anesthesia is desired, it can be easily achieved by withdrawing the needle halfway and depositing the remaining third of the cartridge after a second negative aspiration test. The needle is then removed, and the patient is allowed to rest for the 3 to 5 minutes it normally takes for anesthesia to develop.